CardioVisual. In today's episode, we will explore the concept of atypical chest pain presentation leading up to a heart attack in an athletic patient. The classic symptoms of how heart attacks present are crushing chest pain, sometimes with radiation of pain to the jaws, arms, back, profuse sweating, and sometimes with shortness of breath. But atypical presentations are unfortunately less well understood and recognized by patients to a lesser degree. The danger is obviously a delay in definitive treatment and poor outcomes. Today, we'll meet a patient, Brian Simpson, a healthy 48-year-old male, an avid athlete with no significant cardiac risk factors, who experienced some rather unusual symptoms when he had his first heart attack. In analyzing the 12-lead ECG, the most obvious ECG changes are in the inferior leads. There are ST segment elevations in leads 2, 3, and AVF, along with reciprocal ST depression in leads 1 and AVR. And looking at the posterior leads, there are elevations in leads V8 and V9, and this pattern is highly suspicious for an inferior and posterior wall myocardial infarction. Now let's meet the patient and hear his story. Hello, Brian, and welcome to this episode of Heart Heroes, Frontline Care for Heart Emergencies. Really appreciate you taking the time to come to this program with us. Now, Brian, we've talked about this before, and heart attacks present with typically classic symptoms that people know of, like crushing chest pain, sweaty spells, pain going down the arm sometimes. And you had a very different experience with your heart attack event. So do me a favor and take us through it from the start at the hockey rink.
Yeah, I'd be happy to. So, it was a cold January morning up here in Canada, heading to my weekly Sunday morning hockey game with, a team I've been playing with for a lot of time. And, the game, started off, everything was normal. Big hockey player myself my whole life. And, about maybe a third of the way through the game, I was fighting for the puck and just kind of got stopped in my tracks. And what I noticed in that moment was I had this gold orb, about maybe like 8-10 inches above my right eye, and I had this really weird bodily sensation. It wasn't anything, I kind of likened it to like a little bit of nausea, a little bit of lightheadedness, just a really weird, strange feeling in my body. And I immediately took note of that. I'd never experienced anything like that. I actually skated off and went to the bench thinking, okay, maybe just something's up. I didn't really think anything more of it. As I sat on the bench and it kind of went away, it was, so I was thinking maybe that was just it. Who knows? But for a moment, I literally said to myself, I wonder if this is what a heart attack's like. Mm-hmm. And I was super fit. I'm an avid cyclist. I mean, typically on my team, I could play the whole game. I'm one of those guys. I was the fittest guy on the team. And so I wasn't really thinking heart attack at all. I went back out again for another shift. And again, I was fighting for the puck behind the net. I remember it very vividly. And it came back like 100 times more intense. So the gold orb was still there, but that feeling I had in my body, just super intense. And I literally skated away from the play, which I'm a competitive guy. I would typically not do that. And everyone's looking at me like, what are you doing? I skated to the bench. I grabbed my sticks and I said, I don't know what's going on. I don't feel well. And I'm going home. And so headed off, skated to the dressing room. Again, nobody, including myself, thought anything more of it. And I went into the dressing room. I proceeded to get undressed, took all my shoulder pads, all my upper body equipment off. I then bent over to undo my hockey skates. And when I did that, all of a sudden I had these dry heaves and a shortness of breath. And then all of a sudden I just slumped backwards against the cold concrete wall. And I remember like that vividly. I wasn't afraid. I was just sitting there. I couldn't move. I couldn't talk. I couldn't yell for help. I remember thinking I need to call 911. My phone was within arm's length. I couldn't move. I was fully conscious and aware though. And I was like that, I'm told, somewhere around 30, 35 minutes. We don't know exactly. I was calm the whole time. I've had people ask me, like, well, did you think you were going to die? And not once. And the buzzer went. I knew the guys were going to be coming in. And sure enough, guys started coming in. And the third guy that entered the dressing room took one look, saw me, slumped over against the wall. He was a retired police officer, and he came to me right away and he started yelling at me, Brian, look at me, look at me. I mean, I could look at him, but I couldn't move. I couldn't talk. I couldn't answer his questions. He took my pulse. He said I was cold and clammy, and he immediately said, call 911. The guys called 911. It was, by this point, you know, around 11 o'clock in the morning. Turns out that paramedics happened to be having coffee at Tim Hortons, you know, famous coffee shop in Canada, and they were 5 minutes away. And the guys jumped into action. They were able to get the Zamboni out of the back of the arena. The ambulance was able to come right into the arena, and they were by my side in, you know, 6 minutes. They got me into a stretcher, onto a stretcher, and you know, proceeded to, you know, examine me. Again, I was unable to communicate with them. They gave me an IV, and that brought me back. I was now able to communicate what was going on, what I was feeling. And meanwhile, they're running tests on me. They connect me to an EKG. And having worked in healthcare, I know, you know, what they were doing. And Len, the paramedic who was attending to me, said, look, you're having heart troubles. You're not having a heart attack, but we got to get you to the closest hospital. So they rolled me out on the stretcher into the back of the ambulance, and we headed to the closest hospital, which is about 20 minutes away.
And now you're in the ambulance, right? Let me just kind of break it up. So what you were saying is you were on the ice and you had this orb, not once, but twice. No chest pain. Am I correct?
No chest pain.
Skated off the ice, still no chest pain. Slumped over, still no chest pain. EMS shows up, no chest pain, just this feeling of whatever you're describing, the nausea and things that came on now. And now you're in the ambulance while they think you're having something, a cardiac event, and still no chest pain. Is that correct?
That's correct. Still no chest pain.
Wow. Okay.
So, you know, we're heading to the hospital in the ambulance, and you know, he's given me nitro. He's given me a bunch of clot busters, chewed them up. You know, I believe it was Plavix, and literally, it was in the ambulance that I started having the textbook symptoms. All of a sudden now I felt like I had an elephant on my chest. And I can remember vividly, Sush, it was like I could squirm out from underneath it somehow. I was squirming, and, you know, Len said, I'm going to give you some more morphine to relax your heart. And I said, I remember this like it was yesterday. I really do. And literally, as we arrive, and we're almost into the hospital, Len says to his partner who was driving, the second one's there. I knew what he meant. Again, I worked in healthcare. It was now a heart attack officially. They still, even though they were, you know, showing that, they still took me inside, because now they're at the hospital. So they hooked me up to a more sophisticated EKG. And again, I remember this like it was yesterday. The doctor looked at the screen, looked at me and says, you're having a heart attack. We got to get you to the closest cardiac center. So back into the ambulance I went. And it was one of those things where, yeah, I just, it's really surreal. I don't remember anything else. Once we got back in the ambulance, I woke up on the table in recovery at the cath lab in Peterborough Regional Health Center.
Well, that's quite a story, Brian. You know, that really is something else, because you had no chest pain through this entire thing. And even when they told you you're having a cardiac event, and then the doctor told you you're having a heart attack, you had symptoms. Let's not deny that, but you had no chest pain. And, you know, we're going to go ahead and hear from Dr. Guru Kowlgi right now next about this kind of a presentation, the so-called atypical symptoms and how they present. Especially important in folks like you, Brian, and athletes. So I want to thank you, Brian, for coming on this program with us. It's one heck of a story, and I really enjoy speaking with you, and thanks for sharing it. We'll talk to you later.
Thank you for having me.
So Dr. Kowlgi, thank you so much for joining us today on the program. To start with, tell us a bit about your interest and your expertise in cardiovascular disease.
So thank you so much for having me. I am a cardiologist specializing in heart rhythm disorders. I practice cardiac electrophysiology at Mayo Clinic in Rochester, Minnesota.
Terrific. Now, we've talked about this case. Brian Simpson had a big heart attack with very atypical symptoms. Yeah, he was an athletic fellow, cyclist, played hockey. Yet he had this massive event about 8 years ago, and he's been so really kind and forthcoming in coming out and to talk about his case. In patients like this, especially patients with really minimal risk factors, well-conditioned, athletic people, presenting with these very atypical like symptoms, not the classic, elephant sitting on the chest, things like that. How
Yeah.
common is this, and how often do you see these kinds of patients in your practice, Guru?
Yeah, so it's a great question, and certainly something that sort of adds to the diagnostic dilemma when we see these patients, right? And like you said, the classic symptoms of chest pressure, elephant sitting on the chest, shortness of breath, we don't see that all the time. I mean, we see them, I'll say probably 60-70% of the time, but about 20-30% of the time, they can present with atypical symptoms. And then it's important to realize the groups of patients who present like that. So athletes are certainly one group because one, they tend to downplay their symptoms a lot, because a lot of the
Mm.
times, especially for younger people going into professional sports, they don't want any illness to sort of set them back, so they sort of downplay some of their symptoms, but can also happen in females. So middle-aged to elderly females, they can have an altered sensation of a major cardiovascular event. The reason this happens is manifold. Firstly, it depends on the area of the heart involved. So, if there's a large portion of the myocardium involved, like we see in anterior STEMIs or proximal LAD, proximal right coronary artery lesions, so these patients can have more symptoms, and it can be directly a function of the percentage of the myocardium involved, or could be systemic symptoms like nausea, fatigue, those kind of constitutional symptoms as well. Now, in certain atypical MIs where it involves less myocardium, you can have these referred pain sensations too. So the nerve supply of the heart also supplies nerves to the arm, to the neck. So you can have arm pain, neck pain. So that is variable. There's no formula to predict where the MI is based on their symptoms. But it's important to kind of think of the whole picture as physicians, especially physicians in the emergency room. If something doesn't add up, if their pain is not getting better with pain medication treatment, or they're having these constitutional symptoms, or they have risk factors, then doing an ECG is a simple, inexpensive test that can sort of tell us what's going on.
Yeah, ECG is really the first line of diagnostic testing that's so readily available and inexpensive, right? So, yeah, thank you for that reminder. And certainly our pre-hospital colleagues have the same advantage. They can do a 12-lead ECG, right off the bat on scene. And that's exactly what happened with Brian that saved his life, quite frankly. Thank you for that. Now, so we just talked to Brian Simpson and got his story, and it went something like this. In the skating rink, skating, felt fine. He kind of saw this golden orb over his shoulder and had no chest pain, had nothing at all. Got off the ice, got back in the game, had the same sensation, and then fatigue and felt a little bit nauseous, I think. And then had this episode where he kind of slumped over, didn't lose consciousness, but yeah, no chest pain the entire time. So he was having some, kind of an event going on. Guru, in your assessment, what is during this period of time, right? What is the greatest danger? Now I'm thinking, cardiac wise, arrhythmias wise. What is the greatest danger that Brian, was in this 35-minute period of time while lying there against the brick wall?
That's a great question, Soshan. I think a very important one, because really, when we talk about heart attacks being fatal, we are referring to the arrhythmias that can happen as a result of the heart attack, particularly in the first few hours, first 2 to 3 days. So this time frame, we worry both about tachyarrhythmias or fast arrhythmias and bradyarrhythmias or slow arrhythmias. So in terms of fast arrhythmias, when a portion of the myocardium is involved, these patients are at risk for ventricular tachycardia, ventricular fibrillation. So when the heart goes 200 beats a minute and they're not getting any blood supply to their brain, they can have sudden cardiac death and can lead to long-lasting consequences. And on the flip side, sometimes the coronary arteries supply branches to the AV node, to the sinus nodes, and to the distal conduction system. So patients can have slow arrhythmias like heart blocks, and that can cause them to pass out as well. And oftentimes, when they pass out, it's too late to tell what was the preceding event, but we can get a sense based on an ECG if they're slow with complete heart block versus if they're having ST elevation, a lot of PVCs, you think more tachyarrhythmias. If they're having slow rhythm, you think more of bradyarrhythmias. But both of those can be life-threatening and need to be addressed immediately.
Right. Yeah. Thank you. So both fast is bad and slow is bad. I think historically, looking back at my ER practice, slow rhythms always scared me more because you can't slow them down any further, right? So I'm not sure if cardiologists like yourself feel the same way, but let's just focus in on the tachyarrhythmias in the setting of a heart attack. Let's talk about that. There's a lot of discussion about, VTAC in the setting of a post-MI. Could you break that down for us in terms of VTAC in the post-MI setting, polymorphic VTAC versus monomorphic VTAC? Which ones do you see more? Which ones are more concerning? And how do you approach patients with those two things?
Yeah, again, another great question. So I see both of them, and then both are seen in slightly different scenarios. So polymorphic VT or ventricular fibrillation, I'll sort of club them together.
Mm-hmm.
So these are more seen in active ischemia. So if someone's having a STEMI and they have a part of the heart not getting enough oxygen, so they can have these polymorphic VTAC episodes. The other scenario would be metabolic abnormalities. So electrolyte abnormalities, low potassium, low magnesium. These patients can have polymorphic VT. That is the reason when people have tossards, oftentimes we say give magnesium, because you want to prevent low magnesium causing some of these episodes. On the flip side, monomorphic VT is often always associated with underlying ventricular scar. So these are patients that have had scar tissue from something else, most commonly ischemic cardiomyopathy. So meaning they had a heart attack in the past, they have an area of the heart that has scar tissue. They don't necessarily have to have an active heart attack, but a prior scar tissue can lead to a monomorphic VT. So they managed differently because in polymorphic VT, there will be a reversible cause that you should try and identify and eliminate in the acute setting. Could be ischemia, could be electrolyte abnormalities, could be an offending drug or something like that. In monomorphic VT, you can try to give them drugs to break the rhythm then, but eventually they may need procedures such as catheter ablation to target that scar tissue and to homogenize it to make it less likely to have a VT in the future.
Yeah, that's great advice. We see this all the time, all day long in the ER, and it's just great. It's great to have sort of some sort of an idea of where we're going with these patients because they come in with these two different rhythms, right? So thank you so much for that. And finally, I wanted to ask a question. There's a lot of literature out there talking about the use of antiarrhythmics, and in the pre-hospital world versus the hospital world, the use of amiodarone versus lidocaine, it's up and down, back and forth. The pendulum keeps swinging.
Yeah.
What is your opinion on this?
Yeah, so no, I have certain scenarios like where I'll use one over the other, but I'll maybe summarize for the listeners a little history of how this happened. So I think in the late 90s, early 2000s, we had some trials published in NEJM that said amiodarone is definitely better than lidocaine for cardiac arrest. And over the years, we've realized that it's hard to say that one drug is the clear winner, because we had some meta-analyses in 2016, 2017, more recent retrospective trials with like over 10,000 patients studied, published in Chest in 2023, that show that lidocaine may have a slight edge. But in summary, based on the pharmacodynamic profile of these two drugs, lidocaine preferentially acts on ischemic myocardium better than amiodarone. So someone has a post-MI, VT, or VF, that's the scenario in which I like to use lidocaine. Otherwise, I feel they're quite comparable, and amiodarone is readily available at most centers, and that can be given as a first drug. But if you have to use a second drug, that's kind of where I use lidocaine in our monomorphic VT population. In the polymorphic VT, secondary to ischemia or active ischemia causing arrhythmias, I tend to go to lidocaine first, but that's just my practice.
Yeah, seems like there are doctors who belong in each camp, right? Lidocaine doctors and amio doctors, and certainly is an interesting thing to talk about, I think. So that's
I'll say
great.
one more. That it's hard to differentiate the two without doing like a randomized control trial prospectively, comparing the two. It's a patient population where it is extremely challenging, dare I say, impossible to conduct a trial of that sorts. So a lot of the data would be based on your personal experiences and what you've seen in retrospective studies. So that's kind of what I'm basing my practice on.
Yeah, great point there, Guru. Thank you so much. So look at terrific insight of this case. This is a great case to really dissect out and talk about these points that you have brought up. I really want to thank you for joining us today for this program. We'll talk to you soon now, Guru, okay?
Too much for having me.
Thanks to both Brian Simpson and Dr. Guru Kowlgi for this insightful session. Let's keep in mind the following. One, not all heart attacks present with classic symptoms. As Dr. Kowlgi said, in up to a third of all cases, patients can present atypically without having any chest pain. Two, about 40% of all patients with coronary artery disease present with a heart attack or sudden cardiac death as their very first symptom. And three, a third of all patients in cardiac arrest don't make it to the hospital. So early recognition of a heart attack and their symptoms and getting to the hospital by calling EMS is not only important, it can be life-saving. And with that, I want to thank you for listening, and thanks to CardioVisual for hosting today's discussion.